Hello, sir. Can you hear me?
We can hear you.
Yeah. Start करते हैं. I guess जिन्होंने join करना था उन्होंने कर लिया. So before we begin this, I would like my colleague Abu Bakr, who is a fourth year medical student, to give you an idea about what we are trying to do and what we have made in Pakistan. So Abu Bakr, over to you.
Hello everyone, my name is Abu Bakr Yaqoob. I'm a fourth year medical student at King Edward Medical University, Lahore. On behalf of KemPsych, I would like to warm-heartedly welcome you all. I'm privileged to give an introduction to KemPsych in front of our participants who have joined us today and our guest speaker, Dr. Bhaskar Mukharjee. I'll throw a bit of light on the history of events that ultimately led to foundation of KemPsych. So last year, in the first 2 weeks of September, around 14 students of King Edward Medical University and 1 student of Khwaja Safdar Medical College decided to take part in an internship program organized by Psychiatry Department of Mayo Hospital, Lahore. So the purpose of it was to explore the field of psychiatry for those who had joined the psychiatry ward in their respective 3rd years of MBBS here at King Edward Medical University, and to also to introduce this field to the students who hadn't been able to attend their wards due to Corona pandemic and lockdown situation that was going on last year. So during the session, lectures were delivered on psychiatric illnesses. Patients were examined and discussed. Research papers were also presented and table discussions were held on those research papers. And when the internship was over, we, along with our mentors, directly felt the need for establishing some means to hold these type of co-curricular activities more often. Admitting the fact that psychiatry and behavioral sciences is just a minor portion of our curriculum of MBBS, we decided, with the help of our seniors and mentors, to form a psychiatry interest group for the keen and inquisitive minds, not only of King Edward Medical University, but for all the medical colleges and universities inside or outside of Pakistan, and to bridge the gap. The purpose was to provide us all a platform where together we can teach and learn this fascinating subject that is psychiatry. Now back over to Yosha Bhai, who will start our session. Thank you.
Thank you, Abu Bakr, for introducing us. So before I introduce Sir Bhaskar, I would like to thank him for the last 1 year, जिसमें मैं इनको messages भी करता रहा, and he has been very kind enough to answer my queries and issues related to psychiatry. I guess I could relate to him when it came to the point कि यूं लगता था कि साइकाइट्री साइंस से ज्यादा एक ह्यूमैनिटीज का सब्जेक्ट है क्योंकि शुरू से मेरा अपना पर्सनल इंटरेस्ट भी न्यूरो साइंस में था एंड आई वांटेड टू लर्न मोर अबाउट इट तो आई नीडेड समवन हु कुड एक्चुअली गाइड मी हु कुड एक्चुअली थ्रो अ लिटिल लाइट ऑन इट एंड आई आउट ऑफ नोवेयर आई केम I got added by one of my mentors in a CME group on Telegram और फिर उसके बाद I got into WhatsApp and whatnot. So they have been conducting Thursday musings for the last 1 year, जिसमें they invite people from everywhere. They invited a professor from France, from India, and they are still doing it, and they are doing this wonderful thing. जिसकी वजह से मेरा अपना ख्याल है कि मैंने शायद पिछले 1 साल में या जितने भी टाइम पे वो चीजें अटेंड की है उससे ज्यादा मैं नहीं सीख पाया. So I want to introduce Sir Bhaskar. Sir Bhaskar is right now a consultant psychiatrist, a teacher, an academic person, as well as a neuroscientist in Kolkatta. And before, क्योंकि सर को मैंने पूछा था कि should I introduce किस तरह introduce करूं, and he said introduce me as someone who likes to introduce himself. So sir, kindly introduce yourself please to our participants today. I guess sir आपका mute है mic.
I was muted. Actually, hello everyone and hello my kids from Pakistan. The thing is, I do like to introduce myself because I don't like people telling about me that he is attached to this medical college. He is doing this research. No, that is not me. That is someone who wants to show his academic mind. I am just a fellow student. I don't have any academic mind. I am just like all of you, trying to understand psychiatry, trying to understand the biggest branch of medicine, psychiatry. Yes, you would say biggest. इतना छोटा सा ब्रांच है, कुछ भी नहीं है, थोड़ा सा बिहेवियर है. How it can be the biggest? Actually, the thing is, psychiatry is that branch of medicine that deals with brain, and brain is the master organ of human body. If I say very crudely, then एक छोटा सा brain है, 2 eyeballs are coming out of it, a spinal cord is descending from the brain, and a few nerve ending. That is what we are. We, humanity, are actually this thing. Rest of the body is the vehicle of this structure, and this structure is us. That is why we can replace every organ of body, but no part of this organ, be it eyeball, be it brain areas, be it spinal cord, can be replaced as of now. Because if you replace these things, the whole person will change. That's why psychiatry, dealing with brain, becomes the biggest branch of medical science. It has extension in every medical branch, be it cardiology, be it nephrology, be it gastroenterology. You would ask me how. There is a sub-branch in cardiology, which is known as behavioral cardiology. Behavioral cardiology is nothing but how autonomic nervous system and immune system and endocrine system controls various conditions of heart based on various brain states. So you see, it becomes psychiatry. Then neurogastroenterology, again a super specialty branch of gastroenterology, which deals with brain and GI system. Behavioral endocrinology, behavioral nephrology, every part of psychiatry that is into these specialties are being produced as a separate discipline. But in truth, these are all psychiatry. So ultimately, psychiatry becomes the biggest medical branch. And like all of you who are wanting to do psychiatry and who are doing psychiatry, I am also a student of this wonderful subject. Along with that, I am also a devotee of brain. I love brain. That's the only thing I understand, and that's the only thing I love passionately. So this is what I am. Nothing more, nothing less. And do not add "sir" before me. I am not yet knighted, and I don't ever expect to be knighted. Okay.
Thank you, Dr. Bhaskar, for this lovely introduction. So before we begin, can you take us back to your medical school life? Like what kind of a medical student were you, and how did you come in contact with psychiatry during your undergraduate years?
Yes, this would be a shocking question for shocking answer for most of you, because at present most of the people all over India and world knows me as someone who fights for psychiatry as biological science and who loves psychiatry. But when my journey started, it was not like that. Let me go back to a bit further than my college, then you would understand. Actually, now I am speaking very freely. I am connecting with everyone. But in my school days, I was a very prototype NERD, nerd. You can easily call me nerd. At present, I am a very sociable nerd. At that point, I was a very unsocial nerd. So I had no friends in school days, and everything I wanted to do is I don't wanted to read any of the usual academic books because they used to bore me. So after joining MBBS by just chance, because I gave the medical entrance, but I was more interested in doing genetics. But due to family pressure, I gave the medical entrance. After joining MBBS, I realized that this is the first time in my life I have found something which I like. All the subjects of past professional MBBS, be it anatomy, be it physiology, be it biochemistry, they look like long lost relatives. They were something I could understand. I never could understand most of my school subjects, but for medical subjects, they were super easy and super interesting. So I started to. There was not a single subject in my whole MBBS career which was uninteresting. Yes, FSM was a bit boring. The laws were drag, but that's okay. Otherwise, the toxicology was interesting. Even the direction was interesting.
Yeah.
So I loved all the MBBS. Then what happened is, due to this love and natural interest, I did a good academic performance. And being a nerd, like most other unsocial nerds, I also became a bit egoist and arrogant. So what happened is I wanted to do medicine in AIMS only. No other place would satisfy as a training institute and as a subject. My first exposure to AIMS entrance was not bad. I secured a good rank, but not good enough for medicine. It was good enough for psychiatry, but pagaloं का subject कौन लेता है? I was never interested. Then came PGI entrance. Same thing happened. I was qualifying for psychiatry, but I was not qualifying for medicine. Then come All India exam. All India entrance exam is a whole India encompassing PG entrance where PGs from UGs from all over India compete. And actually, they try for roughly 700 seats of post-graduation. Now the seats are much more, but when my time in 2003, 2004, it was just 700. So I gave the All India entrance. Here, the good colleges of medicine was available, but not the best ones. And so I opted for, ठीक है, psychiatry ले लेते हैं, छोटा सा subject है, क्या जाएगा, पढ़ लेंगे, उसके बाद एक साल बाद नया एग्जाम आएगा, इससे दे देंगे. After entering psychiatry, it was a shock of a lifetime. ये क्या हो रहा है? मैं कहाँ आ गया हूँ? The whole thing is, मैं आ गया, मुझे एक साइकोलॉजी का बुक मेरे प्रोफेसर ने दे दिया, इसको पढ़ो. Every page was a torture. No meaning, no logical conclusion, no scientific explanation, just rote memory. All you need to succeed in psychology is rote memory. Couldn't stand it. I tried to do a lot of things. I tried to fight with my professor. I tried to do a lot of seminars which showed that psychiatry is actually part of basic brain biology, but they didn't agree. And somehow this made me furious that ये नहीं हो रहा है. They don't understand. So let's make them understand. And that actually started the affair of mine with psychiatry. First, it was, hey, ये लोग, this is not psychiatry. There has to be something. I am a physician. I cannot do this type of psychiatry. Then I started understanding brain. And over next few years, for my till my junior residency and senior residency, I tried to read as much neurology as possible. as much neuroscience as possible. And slowly, brain started to entice me. And psychiatry has become a love affair. जहाँ पे मुझे किडनैप करके लाया गया, and I fall into a Stockholm syndrome. Stockholm syndrome doesn't exist. That's a psychology term that has no real world correlate. But for giving example, this is a Stockholm syndrome. Psychiatry kidnapped me and I started loving it. Slowly I understood that everything is brain. Brain controls whole body parts. Brain has multiple level of expression. What we think is cognitive expression of brain. What we feel is emotional expression of brain. What we sense is sensory expression of brain. What we do is motor expression of brain. And when we do things coordinately, and when we go through all this cycle coordinately, that becomes behavior. And behavior is another expression of brain. So ultimately, brain has 5 layers of expression. And we just have done a great disservice to brain by dividing the motor component and sensory component into neurology and the other components in psychiatry. And since then, it has become my...
Sorry, sir. Yeah, sir. Continue, sir.
Yes, yes. It's okay. It happens. In Zoom meeting, this type of things happen. Since then, it has become my goal of life, you can say, or my quest to find myself, that I want to join the 2 sides of clinical neuroscience, psychiatry and neurology, and I want to make psychiatry regain its whole place, the place of clinical neuroscience. That's it. Nothing very special, just a person who was nobody, then became somebody, and then again nobody, and trying to become, he's trying to make his subject something now.
Thank you so much, Dr. Bhaskar, for taking us through all these years. You are very right, because if I remember, if I go back in time, I guess in the start of the 20th century, or at the end of the 19th century, most of the people who were psychiatrists were also neurologists. In fact, there was not a term like psychiatrist at that time. Most of the people were neurologists.
Yes.
So in your opinion right now, definitely you would have received a lot of traction, a lot of resistance because of your views, because people are not yet ready, especially in our country where we don't have those means to study brain, those means to practice neuroscience. Would you like to share your experience? What kind of resistance have you faced, or have you been able to make something out of it?
The thing is, one thing you have mistaken is that the resistance is in our country. No, it's not in our country. Now I communicate with people from all over the world. And ironically, the USA health system, UK health system, these are the 2 health systems which are most resistant to change. India, Pakistan, and Bhutan, Sri Lanka, other Southeast Asian country, they are not that hard to change. Psychiatrists here, initially they resist, but then they listen. When you show them that this is the evidence, this is how brain controls the whole body, this is how these things are happening. When you start explaining to people from Southeast Asia or China or Japan that how brain controls body, how psychiatric symptoms are produced, they are actually ready to listen. Initially, I had a lot of problems. Initially, I was marginalized. I was ostracized. Even nobody used to call me to any conference, so that I corrupt other people. So that I don't corrupt anyone. I was like a cancer, or we can say plague for them. But the views in Southeast Asia has changed. I am seeing the change. But UK system and USA system, they are not ready to listen. For them, it's sell, psychology, it's still psychoanalysis. They are more comfortable as those rather than a pure neuroscientist, because at the end of the day, everyone who is pursuing psychiatry, who is working as a psychiatrist, is a clinical neuroscientist. But in USA and UK, the gap between the basic neuroscience and psychiatrist are huge. In India, in Pakistan, I have many friends in Pakistan, in Sri Lanka, Japan, the gap is getting narrowed. The basic neuroscience and clinical applied neuroscience are communicating, but the other areas, they are not doing that. Yes, another one, the Scandinavian countries, they are also in the same category of USA and UK. Rest of the world are changing. I am seeing the change. Yes, I frequently get angry that these people don't change. Nothing would happen. But when I get calm, when I understand that how far we have come from 2014, when I first came to national level of Indian psychiatry, to 2021, it's a hell lot of change. Today, I work in Bengal. Bengal is in Eastern India. Now, today, people from remotest part of Western India, Northern India, Southern India, Northeast frontier, they actually contact me for their patients. They communicate with me and they want to know what is happening wrong with their patient. Might be they are missing something. If there is anything that can be done by seeing their patients from brain point of view, people have started accepting. It would take a long. Your generation would probably see the change, but the wheels have started rolling. Wheels have started rolling.
Thank you so much, Dr. Bhaskar. Dr. Bhaskar, right now, the participants we have, most of them are medical students. Most of them are in third year of their medical students. Most of them have their first contact with psychiatry during the webinar we have been conducting for the last 2 weeks with the name of Choose Psychiatry. They have heard a lot of psychiatrists. So would you like to tell them what is difference between the psychiatry, the mainstream psychiatry, and the maybe the other side, which is based more on the evidence and more on the neuroscience? So how can you differentiate the both? Maybe you can give a snapshot to them.
Pardon, can you explain more what you are asking? You are asking me to differentiate between the medical psychiatry to what goes in the name of psychiatry, right?
Yeah, exactly. What when you are talking about change, when you are talking about neuroscience, like you have discussed in groups as well, what kind of change do you want to see? And in your opinion, or maybe in the opinion of most of the neuroscientists and neuropsychiatrists, what is happening wrong?
The wrong thing that is happening is at MBBS level and at basic medical graduation level. We people have forgotten that you are the basic structure of medical education start at graduation level. So we need to train the graduates more about psychiatry. We need to teach them psychiatry, because when they are going to pass out as medical graduate, 70% of the patient they are going to see in whatever stream would have psychiatric symptoms as they are one of the presenting features. So there is no way for them to escape psychiatry. And what we are doing, we are not teaching them psychiatry. We are not teaching them how to understand things from brain's point of view. From first year MBBS, we should start teaching them there is a neuroanatomy. The neuroanatomy part is the most neglected part of anatomy teaching. Just 2 or 3 lectures is spared for neuroanatomy, and this was the actually the feature when I did my MBBS in 1997 to 2003, and the same thing is happening today. You people also are getting 2 to 3 lectures on neuroanatomy, nothing more. Neuroanatomy is the essence of anatomy. We should stress more on these things. Then from second professional onwards, we should start integrated teaching. Means, let's say we should take a patient and bring the patient to a pharmacology or physio or pathology classroom and say that this patient has, let's say this patient has these clinical features. These are produced due to this and this change, these pathological changes in brain. This drug affects these pathological changes and would cause this symptom to change that way. That would make you understand how clinically your knowledge can be implemented. We are doing it wrong. We are making it a didactic teaching. No medical teaching should be didactic. We are doing it wrong, but I don't know how we can make it right, because I am just a single person, a single student of science. I don't know how we can change it, but we need to change it.
Thank you, Dr. Bhaskar. A lot of psychiatrists that I have met, they are not very keen on understanding neuroscience. They are more keen on the social aspects. They are more keen on the maybe therapy aspects. And most of them really don't understand even how does an antidepressant work. All they know that these are the guidelines and these are the guidelines we should follow. So in your opinion, आपने जब ये सारा कुछ अपनी practice में भी किया, तो did it help you clinically? Did it help you in making patients better in a good way?
Actually, patients are the most benefited part of neuroscience-based psychiatry or scientific psychiatry or medical psychiatry, because when you see a patient through eyes of brain, you would understand there is no depression, there is no disease known as anxiety, there is no disease known as schizophrenia. These are just symptoms. Whole of psychiatric nomenclature is just first chapter of Harrison. I hope some of you have started Harrison. In Harrison, there is the first chapter is known as signs and symptoms of disease. It deals with various symptoms of various diseases. There is a chapter called fever. There is a chapter called diarrhea. There is a chapter called headache. And then that specific chapter deals with pathophysiology of those symptoms and things like that. The whole of psychiatry is the first chapter. We haven't gone beyond first chapter. Once you see through brain, you would understand that. Then it is easy for you to give drugs, because let's say antidepressant. Antidepressant doesn't work in depression because depression is not a disease. It's just a symptom. So we are feeling low because our brain is not able to handle the functional demand that is being placed on brain, either by our internal environment or by our external environment. So what we need to do? We need to increase the function of brain. That is what antidepressants does. By which mechanism? By number one, temporary neurotransmitter mechanism, followed by long-term molecular mechanism. What is temporary neurotransmitter-based mechanism? Within 30 minutes of ingestion, these antidepressants start changing brain neurotransmitter level. But brain is a very tightly regulated organ. Whenever you increase any neurotransmitter in brain, the production would reduce, as well as the complementary neurotransmitter would reduce. For example, you increase excitatory neurotransmitter. So the excitatory neurotransmitter production would reduce, as well as the inhibitory ones would increase. And ultimately, the neurotransmitter change would be abolished within 2 to 3 weeks. But by that time, the antidepressants would start acting on other receptors, which we are just finding. SSRI, SNRI, they all act on various neuropeptide receptor, various immunokine receptor, means let's say interleukin-2, TNF alpha, all these, their neurotransmitter, all their receptors are also activated by antidepressants. Along with that, antidepressants also change a lot of intercellular signal transduction pathway, and ultimately brain cells start dividing in proliferation zone. Those new cells gets matured and they migrate to various brain areas which are suffering from hyperactivity, and they form new synapse there. Ultimately, there is huge neuroplasticity and brain remodelization, and that's how ultimately the brain function is increased and the low feeling gets reduced. That's how the antidepressants work. And if we understand that, then we would have no problem in treating the negative symptoms of schizophrenia, because negative symptoms of schizophrenia are just this thing happening from some other way. So let's give antidepressant to them. No guideline talks about these things, because guideline in psychiatry are not data driven. All over world, in every subject, the guidelines are data driven. We see a group of patients, we see their outcomes, and we list that as various steps of management. In psychiatry, a few influential people come together, they are regarded as expert, and they give their expert opinion, and expert opinion is published as consensus guideline. This is not data-based, data-driven guideline. This is not evidence-based guideline. This is actually eminence-based guideline in the graph of evidence-based guideline. That's why in psychiatry guidelines fail. But in medicine, in critical care, guidelines are the mainstay of treatment. That is why we need to change.
Thank you, Dr. Bhaskar, for delineating it in detail. थोड़ा सा अगर मैं इसको इस तरह लूं कि definitely the way you see psychiatry is a very beautiful way, and I see it the same way, and I have been seeing it for the last couple of years. Like in most of the people who join psychiatry or who want to join psychiatry, they see it as some field which is not that medical, or
Yes.
a field which is like they would do because they are not interested in medicine or surgery or maybe in other fields, or at times they feel it closer to art or humanities or maybe psychology or philosophy or things like that. Would you like to comment on these kind of things? How do you suggest to students who are not that who are perceiving psychiatry through this field? Is it a right way, a wrong way, or maybe they should look beyond the things?
So here I would just narrate you my experience. When I started, मैं डायरेक्टली बोल देता था, साला आर्ट्स ग्रेजुएट ने दिमाग खराब कर रखा है. These people who are actually humanities people, they flock to psychiatry because they were pressurized into doing medicine and they didn't like medicine. So psychiatry became a sort of refuge for them. They paid for the mistake, psychiatry paid for the mistake. But then a lot of things change. This attitude of mine was in 2012-13. Then I slowly understood that I can retrain these people. If these people who came here because this is a less medical stream, this is more close to humanity, these are actually passionate people. So if we can show them the reason, if we can show that there is another way of thinking which won't disturb their passion but would help them in understanding this subject better and doing this subject better, they would take it. Because passionate people don't like to lie to themselves. They are here, they are doing this subject, they don't like the way the things are going. They love to do humanities, but they are not doing it. So they would actually either help in making psychiatry scientific if we show the way, or they would not obstruct. Over the period of last 5 or 6 years, I have seen a lot of this type of people. They have started asking questions from molecular genetics. They have started asking me what are some of the books that would help us understand molecular psychiatry? See, and please give us easy books, because we don't know molecular science that much, and these are the people who are the honest one. So initially I would say no, these are the bad people. Like, now I have started feeling that yes, these people can be trained. They want to change, and if given a chance, some of them would join as our greatest talent.
Thank you so much, Dr. Bhaskar. Dr. Bhaskar, I was reading a book like a couple of months ago, and they said that psychiatry के अंदर एक बहुत मसला है कि इसके अंदर ना लोग बहुत जल्दी डॉगमेटिक बिलीफ्स बना लेते हैं, मतलब कि शुरू से ये एक मसला रहा है. पहले शायद मे बी for 40 to 50 years we have been totally like American psychiatry जो थी, उससे पीछे अगर हम चाहें तो क्रेपलिन वगैरह की अगर हम चीजें देखें तो they were very based on mind or sorry on brain. लेकिन जैसे जैसे आगे चीजें चलती रही, सिगमंड फ्राइड और दूसरे साइको एनालिस्ट आते रहे, थिंग्स कोई बहुत ही दूसरी तरफ पे जाना शुरू हो गई. और उसके साथ आई गेस आहिस्ता आहिस्ता जो साइको एनालिस्ट से यूएस की साइकाइट्री और यूके की साइकाइट्री पीछे हटना शुरू हुई है. इट्स लाइक 20 years. और नाउ आई सी इट यूएस के अंदर भी दे हैव बीन ट्रेनिंग, उनका न्यूरो साइंटिफिक मॉड्यूल कंपल्सरी पार्ट हो गया साइकाइट्री की ट्रेनिंग का एंड थिंग्स लाइक दैट. तो would you like to comment on this aspect कि आपकी नजर में ये जो साइकाइट्री एक ब्रेन बेस्ड जो कि चल रहा था काम, उससे निकल के एकदम एक ऐसी चीज में चली गई जिसके अंदर बहुत ज्यादा सूडो साइंस इन्वॉल्व हो गई, ये कैसे हुआ और क्या ये आगे भी हो सकता है?
It would happen as long as we don't get the sophisticated technology which would let us see real-time human brain cell and its functioning. So जब तक हम लोग वो टेक्नोलॉजी ना पाले, ये बीच बीच में pseudoscience would take a dig at psychiatry. Why? For that we have to go back more, a few millennium more. Let me clarify. The concept of mind has originated in shamanistic era of medicine. Shamanistic era means, let's say 50,000 or 1 million year ago. That type of medicine that was being practiced all over the world. There was a shaman or medicine man in every tribe, and they used to treat the patients. Now they were trying to explain human body function. Some of the, if you are interested in anthropology and the paleontology, you would find that in history we have found many a time skulls with bones as well as human body parts having clear mark of dissection, because at that time they wanted to know how human body work, but they had no way of knowing what brain does and how brain functions. So they could discover other parts of body, but for brain they didn't know anything. So to explain behavior, they coined the mind and the things like that. Then these shamanistic people, they changed into 4 professions. 4 profession is one profession, they continued as healers, and we are their descendants. Then there is a group of shamans who went into esoteric metaphysics, and ultimately they become the religious people, religious and spiritual people. A group of shamans went into sociology, humanities, arts, and various other things, and ultimately they are the philosophers as well as sociologists, psychologists of today. Then the last group went into arbitrarship, social arbitrarship, then legality, and ultimately the legal profession originated from it. And each of these groups actually added one dimension to mind. Initially it was just expression of brain function, then religious group added their religious angle, the sociologist and humanities group add their humanities angle, then legal group added their total legal angle. So ultimately, mind became a multifaceted thing. Then this was going on for a long time. Greco-Roman philosophers and healers, they tried to disentangle it. Then in our subcontinent, from your area, Susrut, from my area, Jibak, and from southern parts of Indian subcontinent, Charak. These three people has tried to disentangle it again. They tried it and failed. Then this jumbled up was going on till there is René Descartes. René Descartes found that it is impossible to diminish religious influence. So what he did, he actually proposed a duality. Body is different, mind is different. Mind is part of church, religion. Let church take the mind and leave body for science. This was the first mistake. He did a very good thing for science that time, but he gave pseudoscience the whole of mind. And we are actually recurring the pattern every time. Let's say this mind, brain, and body, this joining was due to happen in last part of 17th century, around say 1850, 60. At that time, there was a French neurologist who was the father of neurology. I forgot his name. Can you please make me remember? He is known as father of neurology, and he was also interested in hypnosis. Freud was one of his early students.
Sorry, I don't remember.
I can't remember. So
it's fine. You can send me a text later on. Continue.
Yes. Yes, that neurologist, in his time, actually, we had a unification of mind, body, and brain. He started exploring body. He started giving explanation for neurological disease, and he started exploring hypnotherapy so that he can give some scientific idea about mind. Yes, Sarko. I remember his name, Sarko. Sarko actually tried to unite these things, but again, he had a student, Freud. Freud took this hypnosis idea from him. Freud was a literary genius. If Freud had gone into literature, he would have won at least one Nobel Prize in literature. He is such a prolific writer. He is such a good writer, but he is not a scientist. He was never a scientist. So he came into science. He became follower of Sarko. He got hooked into hypnosis, and then his artistic brain, his writing, and his cocaine addiction produced psychoanalysis. A good example of how imagination derails every form of science. And he created another cult. Initially, we had to deal with Descartes' cult. Descartes' cult has ended at the Sarko's time, and then again Freudian cult started. Freudian cult, psychoanalysis cult. Again, this cult is still going strong. So in future, there is a chance that again this thing would happen. But our only defense against that would be by 15 to 20 years, we would get real-time observation of each neuron and its inner functioning. And with that, there is no way pseudoscience can ever take back psychiatry.
Thank you, Dr. Bhaskar, for explaining all this. It's always a pleasure to hear you on this passionate topic. तो डेफिनेटली एक आप कह लें कि एक क्रिटिसिज्म आता है जब भी वी आर टॉकिंग अबाउट न्यूरोसाइंस इन साइकाइट्री, एंड दैट क्रिटिसिज्म इज के वी डोंट नो. सब लोग कहते हैं कि ठीक है, यू हैव फाउंड कि ये होता है, देयर आर मॉलिक्यूल्स, ये, बट यू आर अनेबल टू टेल द होल स्टोरी. सो वी वुड नॉट लाइक टू make it our clinical practice as long as you tell us the whole story. Well, there is definitely a start and then a middle thing, and then you come across the full story. But again, what do you see? How do you cater the criticism of these people who say that there is no neuroscientific base? We cannot find, and we shouldn't even. Some say that like that in that way.
And actually, their opposition stems from a valid point. The valid, we have to always hear these people, not because we are not indebted to those people who says that I only understand psychology, I don't understand anything else, or I only understand sociology, I don't understand anything else, so I don't understand what you are speaking. These people are not important, but these people who are saying that what you are saying is partial, psychiatry has no basis, or psychiatry is a means for mass domination or things like that, their objection stems from our past. In the past, we have done mistakes. We have to be direct about our mistakes, because unless we say that yes, we have done mistakes in the past, we would never be accepted wholeheartedly. There was a time, I don't know probably whether you know this part of history or not, there was a time when colectomy, partial or complete colectomy, was a treatment for schizophrenia in early part of 19th century, because people thought that toxins from colon used to cause various psychiatric symptoms. So yes, we are sorry that that happened. There is also another very famous Nobel in psychiatry, the frontal lobotomy, and its originator got Nobel. That is a dark past. We have to say that we have done a mistake. We have went overboard over many things. In many things, we have done a great wrong. In Russia, psychiatrists have given validity to various kind of fascism. In Nazi Germany and in various Nazi outfits, psychiatrists actually gave them validity. If we talk about Holocaust, psychiatrist was one of the eager participants of Holocaust. We shouldn't have done that. We have a black history, and that black history would make people question us. But neuroscience is actually bridging the gap. Initially, at present, neuroscience is perfectly capable of explaining anxiety and depression up to each molecular pathway. I can do that actually. Or what we don't know about is psychosis and mania, the two faces of same thing, but how this thing is happening, we don't have clear idea about it. Anxiety is already sorted out by neuroscience. Depression is sorted out. OCD is sorted out. The OCD is not up to molecular level, but much clear level. But mania and psychosis, we don't know how much we need to know and how much is there. That is a point. But yes, we are progressing. We have to be honest that we don't have all the answers. We are trying to get the answers. And every day we are getting new and new evidences in favor of our answer. But like everything in science, we are waiting to be proven wrong and to refine it, because science is always a journey. Science is not a destination. There is no branch of science which can reach its destination, because there is no destination. The journey is science. Finding a truth, falsify it, finding the fault in it, define the truth, again trying to find the fault. That is science. And finally, in psychiatry, we are doing science. That is what I can tell now.
Exactly, Dr. Bhaskar, that's a very valid point. The people definitely there is a voice, and there is a very valid voice, that the research in psychiatry is hampered by DSM, the criterias of DSM and things like that. Uh, it it doesn't help that much. It helped with the insurance companies, it helped with the social people, it helped with the uh, uh, people who wanted to treat and wanted to have over and over patients over and over again for multiple of years, but it didn't help that much to psychiatric research. What are your viewpoints on DSM? Is it helpful, or should we modify it?
My answer would be a bit dramatic. Can you see this tattoo?
Yeah, I can.
Let me show this tattoo. Can you see this one?
Yeah, I can.
This
I
is
can.
psychiatry. Brain and DNA. Problem is, if this is psychiatry, then DSM just become a classification of symptoms, nothing more, and that too imperfect symptoms. DSM, ICD, they are hindrance, because they are saying there is a disease called depression and it has this genetic basis. It cannot be. Depression can happen due to everything in body. Brain is master organ of body. If brain is under stress for anything, a person would feel low. The person's heart rate would increase. The person's respiratory rate would increase. There would be diaphoresis, or that is hyperhidrosis. There would be constriction of blood vessels in skin, and that would lead to cold and clammy extremity. That person would feel there is stasis in upper GI system, because autonomic activation would cause the slowing of gastric emptying, and there would be acidity and other thing. So anything that happens, anything, if you have a fever, this thing, same thing would happen. If you have let's say typhoid, same thing would happen. Malignancy, same thing would happen. If you are facing grief, same thing happen. If you are facing a defeat in a game, same thing would happen. So how come it becomes a disease? It's not a disease, it's just a symptom. Whole DSM, initially till DSM-3, it was a honest attempt to classify the different symptom and finding a taxonomic basis. From DSM-3 onwards, it's a political game. People vote for their disease category. In APA, various, I don't know how many of you are have attended APA, probably none of you. And in future, you would attend APA meetings. You would find that people are voting for their disease category. How can disease category be amenable to vote? Again, ICD is same thing. We have given name of symptoms. Yes, the naming is necessary because the insurance companies don't understand science. For them, they need a code so that they can bill against it. So for insurance purpose, DSM ICD is okay. For people, for general people, we need to give them something that you are suffering from this and this. We should mention that these are symptoms. So DSM and ICD are just names which has some function, but when we start knowing psychiatry, these are useless and they are restrictive. They are hampering our researches. They are making, there is no genes for schizophrenia. There is no gene for bipolar, because bipolar disorder is a make-believe entity. Schizophrenia is a make-believe entity. That's why genes for this doesn't exist. What are the genes for? These genes would have association with hallucination. Hallucination would have a lot of genetic basis. Fixed form belief, or let's say incidental memory, autobiographical memory mismatch. That is not a delusion actually. This has a lot of genetic basis. Rumination has a lot of genetic basis. Anhedonia, feeling low, has a lot of genetic basis. Schizophrenia is just a bigger exophenotype, nothing more. Same goes for bipolar and things like that. So that's how DSM not only is redundant, it's actually harmful. But we have to keep it as a probe till new things are coming.
Thank you, Dr. Bhaskar, for explaining it. So I guess we have been talking like for an hour now. So let's wrap it up. And because it's just so amazing to hear you that it's hard to keep track of time. So someone who is in third year of medical school, or maybe in fourth year of medical school, like the participants we have right now, most of them are medical students. If someone wants to explore psychiatry or maybe clinical neuroscience, would you recommend some books or maybe some writers or maybe some resources that they can use and learn
Yes,
it?
I have a folder dedicated for this very purpose, the basic psychiatry folder. I probably have sent it to you.
Yeah, you have sent me back. Yeah.
And just share this folder to everyone here. The first book should be written is Brain and Behavior. There are two books named as Brain and Behavior. One is Behavioral Neuroscience, another one is Behavioral Neuroanatomy. Start with these two books, then go to the other books, and you would have a very good strong basis of neuroscience, neurology to understand psychiatry.
Thank you, Dr. Bhaskar. And Dr. Bhaskar, there is a question from Sheryar. He is a fourth year medical student. And he says, let me read it to you. I guess, yeah. Dr. Bhaskar, I agree with your viewpoint that psychiatry might just be the first chapter of neurology. Do you think if someone genuinely wants to explore psychiatry, he should originally pursue neuroscience and then relate it to psychiatry? I guess I don't really know what he wants to ask. Sheryar, can you unmute your mic and ask things directly?
Yes, I would be happy.
That would be better.
Sheryar, please unmute yourself and fire away. I would love to hear from you.
Yes. Hi, Dr. Bhaskar. Thank you so much for explaining everything in so much detail and in an amazing way. मैं ये पूछना चाह रहा था कि आपने कहा कि साइकेट्री जो है वो बेसिकली एक हम उसको ये सिम्टम्स, अगर हम उसको कहें कि ये कलेक्शन ऑफ सिम्टम्स है ड्यू टू अंडरलाइंग न्यूरोलॉजिकल डिसऑर्डर्स, तो दिस इज़ अ बेटर एक्सप्लेनेशन. तो मैं ये पूछना चाह रहा हूँ कि अगर कोई जेन्युइनली साइकेट्री को समझना चाहता है, उसको परस्यू करना चाहता है, तो क्या उसे स्पेशलाइजेशन साइकेट्री में करनी चाहिए या न्यूरोसाइंस में करनी चाहिए?
वेरी गुड क्वेश्चन. आई वुड से कि फर्स्ट तुमने जो बोला कि साइकेट्री इज साइंस एंड सिम्पटम ऑफ न्यूरोलॉजिकल डिजीज, this is slightly different. I would say psychiatry is science and symptoms of brain disease, because brain disease doesn't mean neurological disease. The diseases of neurology, they are also actually science and symptoms of brain diseases. Neither psychiatry nor neurology, none of us deal with diseases. Only disease in whole neuropsychiatry segment is glioblastoma multiforme. Unfortunately, there is no other disease. Everything is symptom. Multiple sclerosis is a symptom. Epilepsy is a symptom. If I get chance someday, I might explain it. But today the time limit is less. So I would say everything that neurology treats is also a symptom. So neurology and psychiatry, they are just first chapter of diseases of brain. So to know them, what to do? Ideally, develop a strong basis in neuroscience, along with do either of these two specialization. Means one side, let's say you are going to psychiatry, so you are going to read a book for psychiatry and two books for neuroscience. One book of neuroscience is the comprehensive one, and another book of neuroscience is the area of neuroscience which is interesting to you. This is one area I actually forgot to mention. Neuroscience has few divisions. One is, first large division is basic neuroscience, clinical neuroscience. Clinical neuroscience has two incomplete division. One is neurology, another one is psychiatry. Now basic neuroscience has cognitive neuroscience, Number 1. Number 2, computational neuroscience. Number 3, molecular neuroscience. Number 4, systems neuroscience. Number 5 is connectomic neuroscience or connectomics. These are the 5 branches of basic neuroscience. So if you want to know neuroscience, I would suggest do a comprehensive book which would give you an idea about all 5, and a book which details more about the area which you like. For example, I am a student of molecular neuroscience. I am a student and practitioner of molecular neuroscience mostly. I understand molecular neuroscience better than other parts of neuroscience. This is the area where I work and where I research. But I have an overall general concept of neuroscience. Along with that, I am a psychiatrist and I have read neurology and psychiatry. So you start with general neuroscience, a specific psychiatry book, and when you have an understanding of general neuroscience, you would find out there is one specific system that is becoming more appealing to you. Then pursue that system, and along with that, psychiatry.
Thank you so much, doctor. It answered it really well.
Thank you. Thank you for asking me.
Thank you, Dr. Bhaskar. It means a lot that you found this time and we had this amazing discussion. I'm pretty much sure कि बाकी लोगों की भी काफी हद तक चीजें clear out हो गई होंगी, because the main purpose of all these things was to choose psychiatry, जो कि हमने एक webinar रखा था. उसका बुनियादी मकसद ये था कि वो लोग who are leading the fields of psychiatry, they could share their experience, they could share what makes them passionate about this field, and so that passionate can imbibe in coming generations of doctors. So it means a lot that you took time. So any closing remarks or anything you would like to suggest to cover up everything we have discussed?
Thanks for having me here, because I love interacting with students. I love research.
Dr. Bhaskar.
Yes.
Dr. Bhaskar, ये जो mental illness है, इसको हिंदुस्तान में मानसिक बीमारियां बोलते हैं और पाकिस्तान में जहनी बीमारियां बोलते हैं. तो इनका इलाज क्या तावीज से या झाड़ फूक से हो सकता है?
नहीं होगा. But this would be a one-line answer. The best answer is, as a practitioner, I have noticed a curious thing. For 50% of patients, you don't need to provide any treatment. They need to see that there is a person sitting there who has some authority, and that person is saying them that you get well. This actually cures about 50% of patients of any clinical discipline, not only psychiatry. So if that person who is doing dua daru and tabiz kabaz, if that person is a person of authority for the patient and a patient believes that person, then for initial period of illness at least, there would be some relief. But after that, there would be a relapse, and those relapses cannot be controlled.
Right, Dr. Bhaskar, I guess you gave a lecture. I guess there was a sitting on it as well, the neuroscience of placebo effect. I guess it was like a couple of months back. That was an amazing thing to hear at that time as well. So I guess we should wrap it up. I guess I took the time for 1 hour. Yeah.
Yushabhai, can I ask this a question? I know we're
sure.
time, but
yes.
Sure.
The discussion has steered into a way that this question is तंग कर रहा है मेरे दिमाग को.
पूछते जाओ. I love answering my students.
So
you are my
said
students.
आपने अभी placebo effect का जिक्र किया. Can psychotherapy play a role in treating mental illnesses as well?
Yes.
I will.
Bullseye. Bullseye question. It's the question that should have gotten the best question award. Bullseye question.
Thank you, sir.
Why? Because let me explain psychotherapy a bit detail. In psychotherapy, what therapy does is they systematize hope response. In human being, there are two very strong emotional response. One is hope, and the other one is fear. Both of them are mediated by different limbs of reward circuit, but they are mediated by reward circuit. And both hope and fear manipulation can do a lot of changes in human behavior. Now, what happens in psychotherapy? In psychotherapy, they do two things. Number one, they cause systematization of this hope response. The therapist starts building a therapeutic relationship. The therapist makes the person do this thing, that thing, and instill the hope and trigger the hope that I might get well. So this is the placebo pathway actually. The genetic placebo pathway operates this area. This area is endocannabinoid system. This area is endo-opioid system. This area is neurotropin system. And stimulation of this pathway causes an intense feeling of pleasure and intense feeling of relief, well-being. Then psychotherapy works another way. That is, psychotherapy gives some solution about some trouble the patient is facing. Let's say I am having a relationship problem, but I don't know how to solve it. The psychotherapist is giving some solutions and I am trying those solutions. Now, what happens in a brain which is depressed? The brain becomes hyper vigilant. It picks up every change in environment and it makes those as fear signal. Now, our brain has the counterproductive mechanism that is known as threat appraisal pathway or threat neutralization pathway that is being done by executive circuit. So, by giving real life suggestions, by giving real life examples and works, the therapist actually is boosting up that threat appraisal system and ultimately making the person less scared. So these are the two pathways that causes therapy to work. And because these two pathways are same in every therapy produces similar effect. If you search in net, there is a term associated with therapy, dodo bird effect. Every therapy ultimately produces same result. This happens due to this thing, because both therapy, whatever, there are almost 100 type of therapy, but every therapy ultimately produces these two effects. Along with that, you would find that the explanation for psychological mindedness is based here. You see, we call some patients psychological mindedness. These people would respond to psychotherapy and some people would not respond. These are those people who have hyperactive placebo pathway or who are suggestible. Hyperactive placebo pathway is genetic name, neuroscientific name. In colloquial term and medical term, we call them suggestible. These people are more prone to develop beneficial effect with psychotherapy. So yes, placebo pathway has a lot to do with psychotherapy action, and that is how psychotherapy works. That's why wonderful question.
Thank you.
I guess if someone has any more question, he or she is more than welcome to unmute mic and discuss. And if we don't have any more questions, we would, I guess, yeah.
Sir, I have a question. Sir, how to understand that who will respond to psychotherapy and who won't respond to psychotherapy clinically? While seeing patients, how?
Clinically, there are ways to understand the suggestible people. Let's say a person is in a conversation, if a person is subservient, is giving control to other person easily, in a when a structure interaction is going on, when a person gives another person more value than their own self, when some things comes up and you suggest the person to do something, that person are going to do those things that are instructed without any question. These are the traits, some of the traits of suggestibility, and these suggestible people, they are more amenable to psychotherapy. They are also more amenable to nocebo effect, but I am not going into nocebo effect.
Thank you.
So,
any more
questions from
question?
the audience?
Any more questions? Okay.
I don't
So
think there is any. So we'll wrap it up. Yushibai, do you have anything to say?
I have something to say. Thanks for calling me kids. I love it because yes, research is a very interesting thing. Academics is what I love, but teaching my students and talking with them, interacting with them, grooming the next generation is what I love most. So thanks for having me here, and it was wonderful interacting with you.
Thank
Stay
you so much.
safe, stay well, and stay hungry for knowledge.
Thank you so much, Dr. Bhaskar. It
Thank
means
you,
a
sir.
lot. Take care.
Take care.
Thank you.
Bye-bye.
Okay, bye.